So good afternoon all. Can you hear me at the back? Thank you. Antoinette Woodhouse, Stephen Knuckey, we are from OHID and we're here to talk about some work that we have done to develop the catchment populations for acute trusts across England. So what are the catchment populations? Well, it gives us an estimate for the number of people who use acute trusts and the potential to do so. We believe that acute trusts have an increasing need to understand the populations they serve. Probably speaking to the preaching to the choir right now, talking about the different boundaries and geographies that they are. But as we know, we get our ONS mid-year estimates from the census data. GPs have their GP practice lists. Acute trusts don't have a kind of defined geographical boundary. And there are various definitions and methods used for defining that. So it originated back when we were public health observatories, and there was a informed paper written with the methodology for defining that, and actually John Newton, you were part of that when they developed that paper as well. So what it does, it gives us, as I said, a better understanding of the population at risk. It helps to give us a link between the geographic links and the hospitals. It allows estimates for demographics, deprivation, and it's calculated using the hospital episode statistics, admitted patient care data. We calculate them for 3 types of admissions: elective, all admissions, and emergency admissions. The data is also available split by male and female and quinary age bands. And we have, I think we developed the Power BI dashboard about 6 years ago. And ever since then, we have been adding each year to generate a trend. So at the moment, we have a 10-year trend available. And as we said before, it uses HES admitted patients, care data, and ONS mid-year estimates. So a bit of a background on the methodology and how we do that. So we use a geographical base unit, and that's the lower super output area, because from our pseudonymized HES data, that's the smallest geography that we have available. I use certain lookups, and I have referred to them as NHS Digital. I know they're now NHSE, but as the websites haven't changed, then if you can build them. So I get the full list of acute trusts from the NHS Digital Experts Return Information Collection area called ERIC. Also get the full list of providers, because sometimes there is a disparity between the provider names on the ODS acute trust lookup and the estates one. So just to make sure that we're using ones that everyone recognizes. We mentioned that we use the hospital episode statistics data and mid-year estimates. And some caveats is that we only work with unknown. So we only include patients whose postcodes are aligned to an England postcode. We do include both mothers and babies because as far as we're concerned, that's an activity and it's activity-based and that's been utilized. And we also exclude patients with missing or invalid age and sex because we only want to work with our known knowns. So a step-by-step of how we do that. We count unique patients admitted to an acute trust across a 3-year rolling period. So when I refer to the catchment populations of 2020, that does include 1819, 1920, and 2021 HES data. We take those unique patients at the maximum age of their last visit. We calculate the total number of patients admitted in each MSOA. We calculate the proportions of those patients admitted to that trust, to that MSOA, and we apply that proportion to the mid-year estimates and sum that up for each trust. Just a visualization of that in this example, we've got the 3 MSOAs. We're using Cambridge Hospital as the example for this. And for that MSOA, they had 2 patients. From MSOA 2, we've had 5 patients, MSOA 3, 3 patients. For Cambridge Hospital in total, they've had 10. We apply that proportion. And when you sum it up, we can see that for this example, Cambridge University has a catchment population of 165. When we create the catchment populations as well, we have what you call the proportional flow. And so naturally, the closer that people are to a core hospital, that's where they will go. As you branch out further, then comes more choice and they can choose between two trusts. So the proportion of each of those MSOAs things as you go, that gives us that kind of proportional view. But what we also do is we identify the MSOA that has the highest proportion of activity to that trust. And then so we can define a clean, defined lookup list for dominant providers for that MSOA. We identify what we call the first past the post. And in this example, MSOA 2 has the highest proportion. So for that MSOA, Cambridge University Hospitals Trust is identified as the dominant provider. What that also gives us, just to illustrate, that's the proportional flow, and you can see the gradients that it goes around. But with the first past the post, we have harder, clean line boundaries, and that's used to identify the dominant trust. During the pandemic, or regional field service did a piece of work to use the first past the post lookup list to identify where they saw that there were cases growing in certain MSOAs. They could identify the dominant provider for that MSOA to say cases are going up, there could be an impact on admissions in your trust. I'll hand over to Stephen to take you through the output.
Okay, thanks very much, all. I feel a bit bad talking about this when there's so many people in the room who've probably worked on this a little bit more than I have. So I've worked in OHID for not quite 2 years now. And before that, I was working in a public health team in a local area, and we joined a health hub with the hospital, the local hospital trust. And one of the first things I did when I went to talk to them was I said, where do your patients come from? And they were not really sure of the answer to that. They said, well, if they live, I said, if I live halfway between this hospital and Liverpool, which hospital do I go to? And it was quite a hard question to answer. So by doing this and going through for every MSO in England, MSOA in England is about 7,000 or so, add them all up, then we can map that. You can go on the tool and see where patients are going. You can, obviously, if you're a hospital trust, you probably know a huge amount about the people who are coming to your hospital, about who are actually through the door. Maybe you don't know quite as much about those who aren't coming through the door and might come through next week. And you probably don't know very much at all about people who are going to other trusts. So this gives you a way of thinking about who's coming to your hospital, who's going elsewhere. One of the good things on this conference is that there's been so many people talking about deprivation, talking about health inequalities, which is really music to a public health person's ears. That's fantastic. MSOAs is a geographic area. There's lots and lots of information that we can take out. We can add all those fractions together and then work out, for example, a deprivation level for the whole of the trust. So you could say the patients who end up in our hospital are mostly from deprived areas, but if you can say, from looking across every small area in England, we can say, for example, of course, you will be able to predict that Liverpool University FT has a more deprived catchment than, say, a hospital trust in Surrey, but being able to say that Liverpool University FT has the most deprived catchment of anywhere in England is quite a powerful thing to be able to say. Similarly, being able to say Manchester University's FT has the biggest catchment area of any hospital trust in the country, that is also quite a powerful thing to be able to say. For us locally as well, over here in the West Midlands, today, Sandwell and West Birmingham has the third most deprived catchment in England. So as deprivation being a big driver of health need, that gives an impact on the number of people who are going to end up through the hospital. So the kind of things that we can look at, we know the age profile of each of these MSOAs from ONS data. We can add up all those fractions together and work out what the overall expected modelled age profile of the trust is. Of course, many diseases are related to age. We can look at who's in the catchment and how the proportion of those that come through to the hospital. We can work out estimates of the ethnic groups of the people in the area who are likely to come to your hospital, which may be useful for you as well. We can look at patient flows. So, for example, if you are a foundation trust, you might want to see where your patients are coming from. You probably might know that anyway, but you might not know what the situation is for your neighbouring hospitals or for other parts of the ICB. If you're on an ICB, you might be able to compare between different foundation trusts, particularly if you're thinking about moving services around, or if you're thinking about redesigning things. So this is North Cumbria. You can see where those patients come from. And then we can also look the other way as well. So from a local authority area, which hospitals are those going to? And of course, there will be some nuance within that. For specific conditions, somebody might go to a specific hospital, but overall, and you can split between elective, emergency, or combined, and see, say, for Cheshire East, it might be straightforward where people are going, and there will be geographic links around where people are going to. So that could be a straightforward one. Things might be a little bit more complicated if you were to look at some other areas. So say you are in Cumbria, it's a pretty big area. If you're in South Cumbria, it's quite hard to get to North Cumbria. And it could look a bit more complicated like that. If you're in South Cumbria, it takes you a long time to drive to Carlisle. There's a lot of mountains and lakes and rivers in the way. And when you're on the journey, you will almost certainly be stuck behind a caravan or a camper van the whole way. So that affects which hospitals people attend to, and therefore affects. And also, Cumbria is an area that's got split in the ICSs between Lancashire and South Cumbria have gone together, and North Cumbria's gone with the North East. But you can see why that is in terms of which hospitals people are attending, in terms of the areas that they go to. So that gives us, so as Antoinette said, this has been around for a while in terms of the data, but what's new is that we've got the Power BI tool. It's completely open access. You don't need a login. If we thought about it, maybe we could put a QR code for it. But you can go in and choose the hospital trust or choose the area that you want. If you do a search for trust catchments on Google, it's the first thing that comes up. So that's probably the easiest way of linking to it, because Power BI web links are enormously long. The next thing that we'll be doing, and we've nearly completed, is to use those areas to work out indicators. So on fingertips that you'll have seen John go through this morning, there's measures for, say, a local authority area. What is the rate of, say, for example, emergency admissions for different conditions per 100,000? With these areas, we can work out an area based upon the hospital that the person is going to be treated in. So you can see the differences in those rates, fairly taking into account the different profiles and the different sizes, which gives us a way to compare the health needs, not performance, but in terms of the needs and the demand on different areas, which, as you might imagine, do vary with demographics and other deprivation, etc. Also, we will be updating this with the next census as well. So there's lots for us to do on this, but that information is all out there. It's all free. So hopefully it might give you some thoughts on how you can use it in your ICB or FT or wherever.
If I could come in as well. On the dashboard, on the last link is access to all the underlying data files. And we also have some shape boundary files available there as well. It is due for an update, but we are held up waiting for the for ONS to release the small area populations and hopefully the back series as well. So it's scheduled for the autumn. Thank you.